Welcome to another production by the Millennial Mechanical Therapist. Your hosts, Dr. Joseph Gravino and Dr. Clay Case, are two physical therapists trying to treat health issues mechanically. Listen further for patient cases, guest videos, advantages and disadvantages of the way they practice, and much more. Thanks for tuning in today. Check us out on YouTube, Facebook, and at our website. We hope that you learn a lot from watching this video and you come back for more.
Hello, my mechanically minded friends. I am the Millennial Mechanical Therapist, and today we're going to kind of have another part on why everybody deserves a mechanical evaluation. I think I spoke earlier or another video on a gentleman who had a diagnosis of Osgood-Schlatter's who turned out to be a knee derangement. Today we're going to talk about something a little different. I had a gentleman come in older with anterior shoulder pain, 3-year history, but very poor health. Now, he didn't have a lot of typical red flags per se. He didn't have night pain. He didn't have unexplained weight loss. There was no lethargy, malaise, nothing along those lines. However, he was above 55 with a 3-year history of shoulder pain, which is worsening. And it happened for no reason. And the symptoms did not sound really mechanical. The other big thing is he just had a kidney transplant 3 months ago. Didn't influence his pain, but his health in general just is not well. You know, he was on a lot of medications. He gave me a laundry list of meds that he was on. So, when you see these types of patients, I know everyone, we all have our preconceived notions when we walk into the evaluation room. But, hearing everything just in the beginning, starting with this gentleman, I'm thinking, what is this going to be like today, right? I hope this turns out well. And I was pleasantly surprised. And this is why, again, everyone deserves a mechanical evaluation. So he comes in and, he has a huge loss of flexion and I think abduction. His pain really just is intermittent, which is, give or take, good or bad. But he only really gets it when he's putting on clothes, when he's reaching in front of him, and when he's driving with that arm. So he tends not to drive with that arm. Nothing really makes it better besides not doing those activities. And he really doesn't have anything like clicking, locking, popping, swelling. And he reports that every time he uses it, it's painful, it's exactly the same, and then done. So at least it sounds like he's getting a produce no worse type thing. So maybe we have a dysfunction. Time frame would keep us there. Trying to think this through as we're going. Who knows? His history of poor health. So again, he really only had pain or a loss of flexion and abduction. But he had pain with resistance in internal rotation. And I do a adduction from, here I'll kind of stand up so you see it, adduction from a base position. I assess strength to see if there's pain there at the upper extremities. Something I think Dana Green showed us when I took Part D, and I really, really liked that. Just another objective measurement that you could see if you could change. So we go into that, it doesn't sound spine related, but we screened the spine, there was no loss of motion. I cranked on him into, flexion and extension, saw nothing. And no change on any of his objective measurements. So we go in and with the shoulder, I typically start with extension, some form of extension internal rotation. I do this because, the work that's been done in the extremities has shown that some form of extension or internal rotation really seems to be the biggest group or subgroup of a derangement. You could start in a provocative motion, which would, I guess, would be flexion. And sometimes you can see that and sometimes you really can't in the extremities. And I guess that's a talk for a different time. We won't dive too hard into that. But so needless to say, I started an extension. I just had him actively go into extension. And he said during his pain felt better. But afterwards, when he was there, he doesn't have pain at rest. No difference. And we didn't see any effect on any of the objective measurements. Nothing on range of motion, nothing on strength, nothing. So I have him do this a couple more times, seeing the same exact thing. And I've seen people like this before where during it's better, but afterwards It's exactly the same, and you see no objective measurement changes. And usually what I've found is if you give them some sort of resistance into extension or extension internal rotation, it really, really drastically improves. And that's exactly what we saw here. I had him just use a TheraBand. He went into extension internal rotation. It was decrease, abolish, no pain during movement afterwards. And he had full and free range motion, deflection, abduction, and no pain with internal rotation, but I believe just a little bit with the adduction from a base position. But blew my mind. I wasn't expecting that at all. Going into it, I really didn't think this guy was going to be a derangement. I mean, if anything, he sounded more like a dysfunction, or maybe even an other that I probably wouldn't have been able to figure out with his, slew and laundry list of issues going on in past medical and past surgical history. So here's me, again, why you should never walk in to an eval just, with those preconceived notions that you're not going to be able to help this individual. Because I went in negatively and got pleasantly surprised. And he was pleasantly surprised because, he spent 3 years with this. He's been having issues with his health for a while. And, we were just able to give this guy, almost full resolution on day one of his 3-year shoulder pain. Nuts. So I sent him home with it. And I haven't seen him since. I'm making this video pretty much right after the eval, but amazing. Here's this guy, not to beat a dead horse, with a lot of stuff going on, who the last thing he probably wants to deal with is his shoulder, but it's probably getting too much for him to deal with, so he comes in and boom, gone. I mean, that's nuts. And again, for me, I came in thinking he wasn't going to be mechanical, or it wasn't going to be something that could change drastically, just because he didn't, subjectively he didn't sound like it. With his history, he didn't sound like it could be. It's just, this is truly why people deserve. I said it before in another video. I'm going to say it again, and I'm going to. Everyone's going to hear this a million times if you keep following our videos. I believe everyone deserves a mechanical evaluation, even if they don't sound like they do. Or even if they sound like they don't, or even if they don't want it. As physical therapists, I personally believe our role is to assess and help the patient figure out what they can do about their situation. I'm not so much worried about treatment, because treatment for me always follows the assessment. That's what I think is so beautiful with MDT, is I don't have to figure out crazy types of treatments, because once I assess the individual and I can classify them, even if it's not a typical McKenzie or MDT classification, I can figure out what they, should and shouldn't have, or that I may not be the person that can help them. And I think that's huge. If we want to grow as a profession, we should be putting our stock into our ability to do that, rather than our ability, to do stuff that some people frankly will find doing in a gym. And I find that insulting to us. So I truly believe that is what makes us, a great profession, is our ability to assess. And if we can give them a mechanical evaluation, an MDT evaluation, and make huge changes like this guy, or for other people, at least get them the education that they need to treat themselves, or that they aren't mechanical in nature, or that they are something that we or someone else may be able to help better with, that's power. And we'll be, a bigger doorway to healthcare if we embrace this and do this. Everyone deserves a mechanical evaluation, my friends. I believe it. I hope you're going to find out that you're going to believe it. And I hope that I gave you a little bit of motivation on why to try it, at least a little bit, in both the spine and the extremities. You know what I'm going to say, my friends? Go out there and try it. Move your patients early, move them often, and move them to end range, because that's where the magic happens. Good luck, and see you next time.